All right. Good afternoon, everybody. This is our second session of Emerging Threats for the Frontline Provider. I'm really excited that you're all here. Apologies if I sound a little bit hoarse. I may have contracted a very low acuity, high prevalence viral pathogen of my own, which is, I think, making me a little bit on the hoarse side. We'll jump straight in with just a quick chat about why are we talking about emerging threats at all? Some of you who attended the first session heard me read this quote by Fauci, which is that the emergence of new infections and the reemergence of old ones are largely a result of human interactions with and encroachment on nature. As human societies expand in a progressively interconnected world and the human-animal interface is perturbed, opportunities are created, and this is often aided by climate change, for unstable infectious agents to emerge, jump species, and in some cases adapt to spread among humans. We're talking about Marburg today, Marburg viral disease and Marburg virus, and this quote is really, really true about MVD. We've seen more and bigger Marburg virus outbreaks over the past few years than ever before. There has not been a large-scale outbreak of Marburg virus disease, or MVD, like there was of Ebola in West Africa. But a lot of people think it's really a matter of time. The exposure to the zoonotic reservoir for MVD, which is fruit bats, continues to increase. Often the reservoir has an occupational exposure element to it as well, because exposure occurs for folks who are working in caves along with mining. And so there's an element of connection of this not only to One Health concepts, as there is with a variety of these diseases, but also to emerging concepts around interlinked planetary health and emerging viral diseases. In a more succinct form, what Dr. Fauci is saying here is what Seneca said here. You won't be surprised that the diseases and the potential emerging pathogens are innumerable. All you have to do is count the cooks. There's a ton of potentially high impact pathogens that are zoonoses that exist in animals that have increasing contact with potentially susceptible human reservoirs. And because of that, our fight against infectious disease ain't over till it's over, but it's never over. Emerging and reemerging infectious diseases are going to be a feature of how we manage frontline care, starting now and for the foreseeable future. So what do we mean when we talk about emerging threats? We mean threats that are challenging to predict well in advance of their emergence. Historic prediction of what's going to be the next big one has mostly been wrong. I'm not going to engage in that much in this lecture series because then I'll mostly be wrong. Typically, we're going to talk about pathogens that either have recently or we think are about to, based on current data, suddenly increase in caseload, geographic spread, or incidence. Sometimes those pathogens will be novel, and that'll be the case with things like remixing of influenza strains. Sometimes they'll be reemerging or resurgent, and that'll often be the case with pathogens that are potentially vaccine preventable, but that have decreased uptake of vaccine or other things that are happening behaviorally that mean that we have an increased burden. Resurgent or reemergent infections also can occur because of increased interaction between a reservoir in the world, like the fruit bat reservoir for Marburg virus disease. Lastly, we have the smallest threat, but the one that tends to get a lot of attention and funding, which is that some of these threats are weaponizable and arguably could be deliberately emerging, as in bioterror threats. Many of the case studies that we'll do over the course of this year occur in fragile systems. I'll argue that the case of the Marburg viral outbreak in Rwanda was an interesting case of a system that has been deliberately strengthened to have peak performance in the setting of an outbreak like this one, and that the low case fatality and relatively low case rates, in contrast with the emergence of Ebola viral disease in West African capitals, there was very, very limited spillover after the original infections in this case. And I think that in large part is down to the investment in the health systems in Rwanda. Surveillance and response depend on frontline providers like you, like me, to recognize, flag, and respond to emerging threats. And in this talk, our clinical portion is going to focus a lot on that recognition and response. Many of you that are here today know who I am. I'm going to say it again, not because I don't think you know, but because we're recording this talk. I'm Amelia Pousson, an enthusiastic educator. I work as our education lead for the Center for Global Emergency Care. I'm a tropical medicine geek, and I'm ASTMH certified in clinical tropical medicine and traveler's health. I really love time-sensitive learning. This is perhaps slightly a little less time-sensitive as we are out from the time when we expect to see additional cases in Rwanda. So it does look like the epidemic there is over. That said, I'm a fellow frontline physician. I work a full clinical burden, and I hope that that gives me some insight into the kinds of things that frontline clinicians may desire to know around high impact pathogens like Marburg. So we're going to transition here to talking about Marburg itself. Marburg is a negative sense single-stranded DNA virus. It's from the Filoviridae family, and that's the same family as Ebola. It's primarily a zoonosis, as I've mentioned. It transmits to humans from either the natural reservoir in fruit bats or through intermediate hosts, including non-human primates. The very first Marburg viral disease outbreak was via non-human primates, which is why we know it can happen that way. There were simultaneous outbreaks in 1967 in lab workers who were handling African green monkeys that had been imported from Uganda. In addition to those cases that were identified, there was about 31 cases in that outbreak. There was an additional 32nd case that was later diagnosed by blood test, which gave the lie even very early on at the first recognition of this virus that this virus is always fatal or always has very severe outcomes. The case fatality rate in that original outbreak was around 23%. There were 7 deaths. And something that I'll come to is that the case fatality rate has varied substantially over the various Marburg outbreaks and tends to have been much lower in areas that have the ability to access excellent supportive and critical care. Some basics about Marburg: rare but severe, very similar to Ebola, zoonotic like we've talked about. It's highly, highly transmissible. So after the spillover events that have occurred at the beginning of each of the outbreaks that have been recognized, there typically are cases within family clusters. 3 recent epidemics in Tanzania, Equatorial Guinea, and Rwanda have been larger. We suspect that in some of the other outbreaks, there were missed cases among healthcare workers. The most recent Rwandan outbreak provides a very, very clear insight into the way that Marburg can become a healthcare worker occupational illness and some of the ways that we need to think about these high impact pathogens as healthcare worker affecting in a very intense way. There's currently no approved vaccine for Marburg, but there is a high potency candidate that was tested both during the current outbreak and is currently in phase 2 trials, which I'll talk about a little bit more, and that is from the Vaccine Institute. There was 2 big RCTs in Rwanda around therapeutics. The WHO ran an RCT on remdesivir as a therapeutic for Marburg. And then MBP091 is a monoclonal antibody. Both of those had RCTs done, and we are as yet pending publication of data on both of those. So I don't have data to share with you on their impact, although I can share that they were used. When we think about the historic trend of the Marburg global burden, focusing in just on the past 25 years, there's been 11 outbreaks in sub-Saharan Africa, as well as 2 travel-linked cases, both of which were linked to Uganda. You'll see the yellow pins linked to small outbreaks, and typically these were family clusters. So we have 2 family clusters, both linked to occupational origin in 2007 and 2017 in Uganda, one of which had about a 25% case fatality rate, the other of which had a 75 case fatality rate. A single case in 2021 in Guinea. It's unclear how that one occurred. There's no obvious epidemiologic link in that case. And then 3 cases in 2022 in Ghana, all of which were within a family with a 67% case fatality rate. In 2012 and then in 2023, some moderate-sized outbreaks occurred. In 2023, there was the unusual setting of two moderately sized outbreaks at almost the same time in Equatorial Guinea and Tanzania. Although you might think that there would be an epidemiologic link between them, there wasn't. The genetics of the virus were different, and there was never an identified travel link in the Equatorial Guinea case, which means very likely that there were some cases missing from that. The other thing that was unusual about the Equatorial Guinea outbreak, in addition to it occurring in a part of the world where there was not awareness that there was susceptibility to Marburg virus disease, is that the case fatality rate was 90%. Almost everyone in that moderate size outbreak died. There's been 3 really large outbreaks in the past 25 years. Prior to these 3 outbreaks, the earliest of which occurred in 2000, and the latest of which is the one in Rwanda this year, there was the perception that most Marburg viral disease outbreaks burned themselves out fairly quickly and were relatively unlikely to have large outbreaks. That was also believed to be true about Ebola before the large West African outbreaks. It turns out not to be true of either of those illnesses. It's all about the population and the transmission dynamics that someone ill with this virus comes into. So the outbreak in the DRC in 2000 is very poorly characterized. It was sort of a slow simmering outbreak linked to a number of mining concerns where young men were going relatively deep into caves, having relatively limited access to personal protective equipment for their occupational work, having heavy exposure to fruit bats in those caves. And while it's listed as occurring in 2000, it probably actually simmered over several years. Identified were around 154 cases, and based on the identified cases, which again almost always tends to overestimate the case fatality because lower symptomatic cases may never get diagnosed, had an 81% case fatality rate. The very, very large outbreak in Angola is, prior to the Rwanda outbreak, the only other large outbreak that was very well characterized, had about 252 cases, and had about 90% case fatality. And we'll talk a little bit more about whether this represents changing outbreak dynamics or whether this represents inadequate access to critical care in a number of parts of the world. So historically, these outbreaks, as I've reviewed, tended to be small with under 15 cases, overt bat exposure or occupational and travel exposure to caves. And there had been very limited opportunities to evaluate therapeutics or vaccines because oftentimes by the time something could be deployed, the cases had either recovered or died. And so there had been very, very little forward progress on developing vaccines for the viral class of hemorrhagic viral fevers. These larger outbreaks that have occurred over longer periods of time have had larger case numbers and are being identified by the WHO as representing a potential opportunity to evaluate therapeutics and vaccines. In fact, last year, before this outbreak, there had recently been a WHO agreement around how therapeutics and vaccines would be evaluated and deployed in the case of a new Ebola, Marburg, or other viral hemorrhagic fever within this family. When it came to this outbreak, however, not everything that was planned on was able to be done. And some of that relates to the initial epidemiologic investigation of the Marburg viral disease cases in Rwanda. So the index patient's close relative was admitted to Hospital 1, which the publication of this material has not used the names of the hospitals, but other things published by the Ministry of Health has used the names of the hospitals. I've stuck with the technique that the published papers have talked about, which is calling them Hospital 1 and Hospital 2. There's really 2 main hospitals in the city of Kigali, which is where the vast majority of these cases occurred. And that is King Faisal Hospital, which is abbreviated as KFH here on the image on the screen, and Sashuka, which is the main teaching and public hospital in Rwanda. The index patient's close relative was admitted to Hospital 1, and you can see that that person you can see is indicated as COO or C00 on the screen. They were admitted at the end of August 2024, but they succumbed to their illness prior to definitive diagnosis of Marburg. It's highly probable that this person infected healthcare workers at Hospital 1. where at the end of September, and specifically between 22 and 28 September, there was a rapid confirmation of 26 cases in healthcare workers at Hospital 1 and around initially 3 cases at Hospital 2. There was very limited genetic variation between the sequencing of the virus in all of these cases, suggesting that there was a very recent common ancestor, and that there had been relatively little genetic drift in the virus between infections between people. There were a couple of cases, including a student at the University of Rwanda and a farmer who was diagnosed upon presentation to the hospital that was less affected by occupational cases. But those epidemiologic links have not, at the end of this epidemic, been able to be elucidated further. It's unclear where those people were infected. There was also significant concern in the beginning of the outbreak for ongoing transmission, given that the spouse of the index patient left the country and traveled to Belgium. She ultimately did not develop infection, was not symptomatic, but it's something that has come up a lot in the narratives of what it was like to work during this pandemic from Rwandan authors that I'll share in just a minute. This slide shows how quickly the caseload peaked and then went away. So the pale blue line is number of patients under treatment. The dark blue line is the cumulative number of cases, and the light gray line is the recovered patients. The 11 total deaths that were present as of October 2 grew ever so slightly. At the end of the pandemic, there was a few more deaths, but the vast majority of the deaths were among healthcare workers, other than a couple of the index cases. The cases were reported in people whose home was in 7 of the 30 districts of Rwanda, which speaks to a little bit of how geographically compact Rwanda is. The 3 districts, Gasabo, Kikiru, and Nyiragongo in Kigali province, had the highest number of cases. So those were clustered around the capital city. In addition to these confirmed cases that you can see on the chart here, there was about 600 in total contacts to cases that were monitored for symptoms and followed for at least 21 days after their last contact with anyone who did develop Marburg viral disease. The genomic analysis of this confirms that this, like other MVD outbreaks, had a single zoonotic spillover. There was a single spillover event, probably not in the index patient, probably in someone who was in contact with the index patient, that triggered the outbreak. The person who was originally infected, who infected the index case, was thought to have exposure in an old mining cave to Egyptian fruit bats, which are pictured here and don't look nearly terrifying enough to be the main zoonotic reservoir for a pretty serious illness. The Rwanda Biomedical Council achieved near real-time tracking and surveillance of cases, which is incredibly challenging to do. There was substantial human-to-human transmission in this outbreak. It primarily involved healthcare personnel. It was very sensitive. The Rwanda Biomedical Council and the Rwanda Ministry of Health elected to use the social media service formerly known as Twitter, now known as X, to publicize real-time updates of caseload, number of people recovered, number of people vaccinated, and they published that just about every single day over the course of the entire pandemic, which I think is a really interesting insight into how the Rwanda Biomedical Council and Ministry of Health saw their responsibility to the public in managing a high-impact illness, and contrasts significantly with, for example, how Canada managed their SARS outbreak, or how other countries have managed their viral hemorrhagic fever outbreaks over the past couple of decades. Some takeaways from this outbreak are that health preparedness, investment in health preparedness, especially at a national level, looking specifically at infectious disease surveillance and public health systems can bear dividends when you least expect them. Rwanda's eye at the time of this outbreak was really focused on Mpox, which is what we talked about in our last lecture in this series. They continue to have a fair number of Mpox cases, and they were not looking to have a second parallel outbreak, but they did and responded to it remarkably well. Some of that is down to the fact that about 90% of the population in Rwanda have health insurance, which is much higher than many of its East African neighbors. There's been national investment in a strong infectious disease surveillance system, and they have a history of successfully containing outbreaks in the past. Geography matters. Early care in an urban center by one of the index cases really modified the meaning of occupational cases. In other outbreaks, when we've seen occupational cases, it's because someone's been bopping around smaller hospitals that don't have the capability to recognize what's going on with them. And the presence of occupational cases is a very bad sign because the outbreak may have been smoldering for some time in the community and only becomes apparent when healthcare workers begin to get infected. That wasn't the case in this outbreak, and Rwanda's use of infection prevention and control strategies was also, I think, key to making sure that unlike some other viral hemorrhagic fever outbreaks, this was really contained, even though the cases were right in the capital. Some really interesting perspective on the narratives of survival for people who are caring for or infected with Marburg have been published, and I want to strongly shout out the opportunity to read these. The first one is here in the New England Journal. It's entitled Fight or Flight, Facing the Marburg Outbreak in Rwanda. It's by a physician who discusses being pressured to transfer out one of, or both actually, of the first two critically ill cases of Marburg, and being involved in the decision to not transfer them out, as well as the decision to raise the flag of, I think this might be a hemorrhagic viral fever. This other paper here is in Lancet Global Health and speaks specifically to gender dynamics about being first responders to the Marburg viral outbreak. The QR codes are there if you'd like to scan them. We'll also circulate the slides. One paragraph from this latter article that I thought was moving was speaking about the fact that gender dynamics don't just affect how we choose who leads outbreak response, how we choose folks who are on the front lines, but it affects everything about the day-to-day work of people who are doing this. So the authors of this paper said, we urgently need personal protective equipment designed for women by women. Current personal protective equipment is tailored for tall men with short hair, leaving women like us inadequately protected against disease. PPE should fit people like us and ensure our safety on the front lines. We need more data on experimental drugs and vaccines for women, specifically safety profiles and efficacy data in women who are pregnant, lactating, or both. Both of which are concerns that I don't often see raised in the medical literature, and was really, really pleased to see raised here by these first responders. This lecture series is in part talking about diseases that have the potential for global spread. And so I will say, I think that the chance of future outbreak initiation outside the region is relatively low, although non-zero. Transfer of ill patients was requested, as I've mentioned, at the outset of this outbreak, and could have led to significant regional or trans-regional spread. So I really recommend anyone who's interested in this to read that first article that I linked, because I think it speaks to how much impact a single frontline clinician can have in making decisions that affect the trajectory of an entire pandemic. The last part of this is going to be talking just a little bit more about the clinical management of Marburg. So the clinical features and risks of spread for MVD closely resemble Ebola. Supportive care, infection control, and other response measures are identical. A lot less is known about Marburg viral disease than Ebola viral disease, because there hasn't been a recent large-scale outbreak equivalent to the Ebola viral disease outbreak from 2014 to 2016. And so the fact that this outbreak occurred in a capital city, in a place where a lot of the people affected were healthcare workers and were made available to them, intensive therapeutics and diagnostics has allowed us to learn a lot more about Marburg. As best as we can tell, the typical time course and phases of illness for Marburg viral disease looks like this. First, there's incubation. Incubation lasts from 5 to 10 days, but ranges up to 21 days, and is most likely related to the infectious dose and the route of infection. Transmission, unlike COVID, does not occur during the incubation period. The clinical course is then divided into 3 phases. First, generalized, early organ, followed by either a late organ phase or a convalescence phase. Generally, the generalized phase lasts from about 1 to 4 days from the start of symptoms, and the early organ phase starts around day 5 and lasts until the completion of about the first 2 weeks of illness. At that point, or even before, patients tend to either recover by spontaneously eradicating the virus, or enter a late organ phase where they have the most severe manifestations of the illness. Survivors rarely show the most severe symptoms and may never reach the late organ phase. So that third phase is generally one or the other. The onset tends to be fairly abrupt with nonspecific flu-like symptoms. Often there's a high-grade fever, more than 39 Celsius, a bad headache, chills and rigors, myalgia, asthenia or prostration, and pretty bad malaise. So very much like influenza. In about 3/4 of patients, they will then develop a rapid onset of GI symptoms. So nausea, abdominal cramping, vomiting, and diarrhea. And that usually starts within about 2 to 5 days. Days 5 to 7 tend to be when people experience the worst of their illness. People often develop their first manifestations of jaundice, coagulopathy, and platelet dysfunction at this point. Those forms of coagulopathy can progress to DIC, and that's when we get most of our media depictions of Marburg viral disease as a viral hemorrhagic fever. I will say that hemorrhage from any mucosal site is actually relatively rare, doesn't occur at all in many patients with Marburg viral disease, or if it does occur, occurs in a small fashion. They have a petechial rash, they'll have maybe some blood-streaked diarrhea, rather than the catastrophic way that it is presented in popular media. Now, gastrointestinal hemorrhage can occur, can be a perimortem finding in patients who are very, very critically ill. More common prior to that is the development of neurologic symptoms like agitation, seizures, hypoactive delirium, or even coma. It's unclear if this is driven by hyperammonemia in the setting of liver injury. Liver injury has been presumed as a significant feature of both Ebola viral disease as well as Marburg, and does seem to occur with some degree of regularity. In the convalescent phase, in patients who survive the early organ phase and do not progress to the late organ phase, often they don't feel great for a while. Joint pain, chronic uveitis, recurrent orchitis, recurrent hepatitis, recurrent pericarditis are all very, very well documented as complications of both Ebola viral disease and Marburg, and recovery can occur over months. There's a variety of skin sequelae that can also occur that are poorly understood, including hyperhidrosis, significant hair loss, and body-wide skin desquamation. The original outbreak that was lab-linked in Europe in the 70s led people to erroneously think that Marburg was less virulent than Ebola. What we know now is that Marburg very likely has equivalent morbidity and mortality to Ebola, and can have case fatality rates as high as in the high 80s%. There was hypothesis that what's called the Angola strain is more virulent than other Marburg viral strains. That's not been supported on the basis of molecular genetics of the strains, but is favored to be in the setting of just the ability to access supportive care or not. In terms of the CDC Action Network guidance for Marburg viral disease, similar to many other illnesses, it comes down to geography, symptoms, and risk factors. So patients who've been in an area with active MVD outbreak in the past 21 days, who have care-seeking behaviors around ILI symptoms, especially if fever is present, and who have risk factors, which include direct contact with a symptomatic person, experienced a breach in IPC control, and were exposed to body fluids for a patient, participated in funeral rituals or physical care for someone during their illness in an active MVD outbreak, or the traditional epidemiologic risk factors of contact with cave-dwelling bats. All of those are included in the Health Action Network guidance. I will say that backing up from this, which I don't actually find that helpful to the frontline clinician, the general principles of managing fever in a return traveler, I think, are maybe a little bit more helpful here, which is that common things are common. Malaria, COVID, influenza, typhoid are all going to be much more likely than Marburg viral disease, even when a Marburg virus outbreak is happening somewhere in the planet. That said, co-infection is possible. So just because you've diagnosed something, for example, malaria in someone who just flew back from Rwanda when an outbreak is going on, doesn't mean stop precautions, because early implementation of isolation precautions does prevent spread and harm. The vast majority of people who prevent for care are sort of in the dry stage of their illness. They're not yet having significant vomiting or diarrhea where they're at high risk of spreading disease to others. And so implementing isolation precautions at that point helps make sure that you're going to have as little nosocomial spread as possible. This is referred to as the 3 I's. So identify, isolate, and inform. Our triage strategies to identify are going to look like having the triage process have a peel off for people with potential viral hemorrhagic fevers if your frontline facility receives people who have recently traveled to areas where an outbreak is happening. If the person has compatible symptoms, which, just to review, are going to be nonspecific in the first phrase, headache, myalgia, nausea, vomiting, almost always with associated fever, and our travel and time characteristics are true, they've traveled to the site of a viral hemorrhagic fever outbreak, or they've had contact with a viral hemorrhagic fever patient in the 21 days prior to the onset of their own illness, well, then we're going to isolate, implement, and inform. What does that mean? We're going to put them in a single room with a private bathroom and with the door to the hallway closed. We're going to do standard contact and droplet precautions. So that's gown, face mask, eye protection, and gloves. And we're going to report to infection control personnel and the local health department immediately. Don't reinvent the wheel. If you are trying to develop isolation guidance for your facility, excellent guidance already exists for infection prevention control for patients with suspected or confirmed viral hemorrhagic fevers. This one from the WHO is targeted at lower resource settings. There's one from the CDC that is targeted at US-based hospitals. In addition, there are excellent video-based instructions for donning and doffing PPE. And if you're doing this for the first time after not having cared for someone with a viral hemorrhagic fever before, take 6 minutes, watch one of the videos. I've linked one that I think is really, really well done here at the QR code. Once you've got your patient isolated, you've got to inform somebody. So knowing in advance where to find your institutional guidelines and linkages to policies and procedures to guide your infection control, isolation, testing, referral, etc., allows you to cognitively deload when you're caring for a patient where you have a concern for an emerging threat. For Marburg, this is the CDC's Viral Special Pathogens branch, which is abbreviated as the tongue twistery VSPB. They're available 24/7 if you think you have a patient with Marburg viral disease or other viral hemorrhagic fever. This is the phone number, and it's answered 24/7. And when they pick up the phone, you say, I need to speak to the Viral Special Pathogens branch on-call epidemiologist. And they'll talk you through whether it's reasonable to suspect, and if it is reasonable to suspect, what to do next. We'll spend just a couple more minutes talking about it. But what I would really recommend is just feeling really solid about what are your policies locally to inform if you have a patient who you suspect has a viral hemorrhagic fever. In most situations, specimens are going to need to be tested. So all suspected cases of Marburg viral disease will need lab testing rather than clinical diagnosis. There's 13 regional emerging special pathogen treatment centers. Hopkins is one of them. All of them have the ability to test for Marburg viral disease, as well as a number of other high-intensity pathogens using an assay called the BioFire Film Array NGDS Warrior Panel, which is another mouthful. If you are curious, you can look up regional emerging special pathogen treatment centers and find the one that is closest to you. There's 13 spread across the continental US. Some do's and don'ts: know your local policy about viral hemorrhagic fever testing and samples. If your facility doesn't have the appropriate risk mitigation capabilities in the lab, which it may not, those specimens will need to be forwarded using appropriate packing and shipping requirements to another facility that does, and it's likely that it'll be one of those 13 testing centers. You'll be guided by the CDC in that if you end up needing to call their hotline. Last things, because this is a clinically focused series, although I sometimes get in the weeds a little about all of the interesting epidemiology around these outbreaks. Some disease-specific treatment strategies that have been elucidated over the course of the Rwandan outbreak are two new things that we didn't have good data on before. The first is these neutralizing monoclonal antibodies. They were used in the Rwandan Marburg outbreak with pending publication of the effect. There had been prior phase 1 study data, but no real clinical data. It had been given to one person who had had a needle stick with a suspect patient who didn't end up having Marburg viral disease. So they really hadn't been tested. The experience of the patients and healthcare workers who received this was that they had very few side effects. The monoclonals are given as a single 2-hour IV infusion. The dose is 100 milligrams per kilogram. Many of the people who were ill with Marburg indicated that they felt like getting the monoclonal antibodies reflected a trajectory change in their illness. They felt like they were getting progressively sicker, and soon after, within 24 hours after getting this, they started to feel significantly less ill. So we'll see what the data shows us about that, but the narratives of patient experiences suggest that it's a well-tolerated medication at a minimum. In terms of vaccination, there were already phase 2 vaccine trials using the Sabine vaccine in Uganda and Kenya prior to the outbreak in Rwanda. There is now also a phase 2 vaccine going on in Rwanda in the region where the outbreak is thought to have initiated. And there was broad healthcare worker ring vaccination in the Rwanda outbreak. The vaccine is designed to prevent illness before exposure. It's not yet been proven to have clinical benefit for recipients, as is maybe obvious from the fact that it's still in phase 2 trials. But again, I think one of the things that's really interesting about this outbreak is that the vaccine, which was not being rolled out in large numbers, was able to be rolled out within a matter of a week, with literally thousands of doses being shipped to Rwanda in order to achieve this ring vaccination. And this is in big contrast to the West Africa trials, where many of them were rolled out in a fairly shambolic fashion. There was not a lot of centralized oversight, and there was big delays in getting vaccines to in-country. And that had been recognized as a source for, as a site for improvement. And I think this outbreak shows that there's been significant investment in the national and transnational systems that are necessary to make that possible. Lastly, before we wrap up, I'm just going to talk a little bit about critical care for Marburg viral disease. The most common complications of people who have MVD are electrolyte abnormalities, anemia, thrombocytopenia, and coagulation abnormalities like hemorrhage and DIC. We see those in both the early and the late organ phases. And the good news is that all of that can be supported with regular critical supportive care. So volume and blood product repletion, maintenance of blood pressure, and oxygenation using positive pressure ventilation if necessary, electrolyte replenishment. And with those key supportive strategies, it looks like the case fatality rate for this illness is likely to be lower than has been seen in other outbreaks where there was no access to this kind of care. Critical care is essential care in high case fatality rate illnesses like Marburg viral disease, and just generally in health systems. And that's part of the eco approach that the WHO is taking to health system strengthening. The case fatality rate was 23% in the Rwanda Marburg viral disease outbreak, and 2 patients who required mechanical ventilation survived. That's never previously been seen in Marburg viral disease. Everyone who required sort of intensive level of care, including ventilation, had died in prior outbreaks. And I think it speaks to the value of a mature critical care system, but also speaks to the burden that this put on critical care workers, who are few in number in Rwanda, and they lost some of their most experienced personnel from both nursing and physician cadres in anesthesia and critical care. So while there are big lessons to be learned from this outbreak, they came at a really significant cost of significant healthcare worker morbidity and even mortality. Um, uh, an additional healthcare worker who died was an emergency medicine resident. Um, and so I think it's important to acknowledge that many of these illnesses, many of these high intensity illnesses really don't care about things that we care a lot about as people. They don't care that someone's in the beginning of their career. They don't care about the fact that somebody is dependent on to help make their systems work. And infection can happen to anyone, but often does happen to healthcare workers. And systems that think about how to protect our healthcare workers before, during, and after outbreaks like this one are going to be increasingly important as we see more and more emerging outbreaks. Thank you for your time. Please, if you are watching this lecture, I would love for you to scan this QR code and complete a feedback survey. We at the Center for Global Health, our Global Emergency Care, are really happy to be able to do lecture series like this, but hope to make them better, more useful, helpful to you. So if you are able to complete that feedback survey, even if you've completed it on a prior lecture, I would very much appreciate you completing it again. Thank you for your time. And I've been watching the clock and my time is up. So I'll stop here. If you have questions, please feel free to send them in the chat. We'll stop recording and allow any questions that you might have to get asked and answered.